Hello everyone. So today is this last topic, induction of labor. Many of you were having the problem in the quiz about this topic. So let's start it. Induction of labor. What is induction of labor? Induction of labor is inducing the labor pains if they are already not, if they are there and it's mild, we then augment the labor pains. Okay. Usually the induction is done at the term unless and until there is specific indication of early induction. For example, we do early induction in preeclampsia and abruption. In all these two cases, we do early induction of labor. Usually we do it at term. Okay, so this was a question which was in the NEET PG last time, and I have given here in the most simplified form. Gravida 2 para 1 present at 35 weeks. She has no complaints and is appreciating fetal movement well. She had a previous classical cesarean at 25 weeks. Ultrasound this time showing breech. What is the best management? So as it is a previous classical cesarean, so this time it has to be elective cesarean at 37 weeks. Okay, a classical cesarean is never given a trial of labor pain. Number one. Number two is you 50% of you have marked spontaneous delivery and do internal podalic version. Please, here I would like to tell you, internal podalic version is totally contraindicated in modern obstetrics. These days only indication of internal podalic version is second twin. If the second twin in the twins delivery, first twin has delivered and the second twin is in the transverse lie, then we can do internal podalic version. Why we don't do the internal podalic version, why it has been contraindicated these days? Because internal podalic version cause uterus rupture. Okay, so I was shocked when I saw 50% of you were marking spontaneous delivery and do internal podalic version. Beta clue is here. Previous classical cesarean can never be induced labor. Okay, so no versions, no ECV, no internal podalic version. So here I am telling you these are the contraindication of induction of labor pain, or you can say these are contraindication of normal vaginal delivery or vaginal birth after cesarean, or these are absolute indication of cesareans. Okay, number one is CPD. If there is CPD, how a baby will deliver? Okay, we already have done in the previous video that how we will find the second stage arrest, active phase arrest, that all this, in those all CPD cases we are going to do the cesarean. Okay, next it is that central placenta previa, we are going to do cesarean. Transverse lie and the brow presentation, we are going to do cesarean. And in the mento posterior, in the face presenting part, we are going to do the cesarean. Okay, previous one classical cesarean is an indication of cesarean, or it is a contraindication of induction. Hysterotomy, previous one hysterotomy. Hysterotomy is any scar on the uterus if there is other than the lower segment cesarean section. If there is any other scar on the uterus, we are not going to induce that patient for labor pains. Okay, previous two lower segment cesarean section are contraindication of induction of labor. Active genital herpes infection is contraindication, and that should be primary. Okay, so these all are the 5 contraindications of induction or normal delivery. Okay, so you have to remember it by heart. Now let's study what are the medical method of induction. Okay, cervical, we have to do ripen the cervix if it is not ripened. Okay, so mainly we ripen the cervix by prostaglandins. So there are 2 prostaglandins which we can use. That prostaglandin has to act on cervix. Only 2 prostaglandins act on cervix. The one is prostaglandin E1 and prostaglandin E2. Here you are never going to mark that we can use F2 alpha. F2 alpha does not act on cervix, and we are going to never mark that if we can use F2 alpha. Okay, or carboprost. So we use only 2 prostaglandins for cervical ripening. Prostaglandin E1, that is mesoprost or gemprost, and prostaglandin E2, dinoproston. So you all have complained me ki we don't remember their names. E1, so what do you mean by 1? 1 is a topper. So 1 is a topper. Main, meso means main, and gem is जेम चैंपियन. ओके, सो वन वाले को हम मीजो मेन बोलेंगे और जेम बोलेंगे. ठीक है. देन PgE2 मीन्स टू मीन्स दो. डायनोप्रोस्टोन, डायनोप्रोस्टोन में भी दो है. द अदर एजेंट, मेडिकल एजेंट which you can use is mifepristone. Mifepristone is anti-progestogen, so we can use it. The third thing is oxytocin IV drip infusion. Here you have to mark that it is infusion, not bolus. Okay, if the cervix is good effaced, is like 80% 90% effaced, then we prefer oxytocin. If the cervix is not good effaced, then we prefer prostaglandins. Okay, mifepristone is a new drug, not much is there for you to read, so you just have to remember that if cervix is less effaced, then we have to use prostaglandin. If cervix is good effaced, then we have to use oxytocin. What are the side effects of mesoprost? Here I'm talking about just side effects of mesoprost, not all the agents. These are only restricted to mesoprost or your gemprost. It is hyperstimulation. It causes hyperstimulation, increased pains. That is particularly seen in the heart diseases and VBAC. Okay, because it causes increased pain, hyperstimulation, hypercontraction. So it is not given in the heart diseases and the VBAC patient. Then it causes fetal distress, and at the last it causes scar rupture. So that is why we use it very cautiously and keep on monitoring the patient whom we are giving the induction. Okay, so these are some of the side effects. It happens less often, but yes, they happen. The mechanical method is striping of the membrane. We just put a finger below the membrane and we stripe it. Okay, that is striping of the membrane. Number 2 is ARM, artificial rupture of membrane. We do it with coccus scatula, and here the IRM is, it is contraindicated in heart diseases and IUD, intrauterine death and heart diseases, because there is leakage of the fluid and it increases the infection, so it is contraindicated. Foley's balloon catheter also is happen. So these are some Foley's balloon. Can we insert the Foley's? We dilate the balloon of the catheter, and then we keep it there, and it slowly it causes the dilatation. Okay, other methods which we can use but they are obsolete, still I'm writing here, is laminaria tents. These are hygroscopic methods. Okay, laminaria tents. Okay, and one thing more, this was a question of June 2021 FMG, that if the oxytocin is given IV bolus or stat, okay, right way we are giving, then it causes hypotension to the patient. Okay, this is a side effect of oxytocin. So these are all about the induction of the labor. I hope now your confusion is clear, in which cases we have to do labor and which agent we have to use. Okay, keep revising. Thanks for watching my video. Do like, share and subscribe and help me in my teaching journey. Thank you. See you soon in the next video.